Question 1. A 68-year-old client with small cell lung carcinoma is admitted with confusion, nausea, and headache. Laboratory results reveal serum sodium of 118 milliequivalents per liter and low serum osmolality. Urine sodium is elevated. Blood pressure is 118/70 millimeters of mercury with no peripheral edema. Which pathophysiologic mechanism most likely explains this client's hyponatremia? A. Excessive aldosterone secretion. B. Inappropriate antidiuretic hormone secretion. C. Renal sodium wasting due to acute tubular necrosis. D. Hyperglycemia-induced osmotic diuresis. Answer: B. Inappropriate antidiuretic hormone secretion. Rationale: small cell lung carcinoma commonly produces ectopic ADH, leading to SIADH. ADH causes water retention, diluting serum sodium and lowering serum osmolality. The client is euvolemic with high urine sodium, which is classic for SIADH-related dilutional hyponatremia. Question 2. A post-operative client receiving hypotonic IV fluids develops irritability and muscle twitching. Serum sodium is 122 milliequivalents per liter. Which nursing action is the priority? A. Initiate seizure precautions. B. Restrict oral fluid intake. C. Increase IV fluid rate. D. Administer potassium chloride. Answer: A. Initiate seizure precautions. Rationale: severe hyponatremia, less than 125 milliequivalents per liter, increases risk for cerebral edema and seizures. Airway and neurologic safety take priority. Fluid restriction is appropriate, but not before preventing life-threatening complications. Question 3. A heart failure client presents with sodium level of 130 milliequivalents per liter, peripheral edema, and crackles on auscultation. Which type of hyponatremia is most consistent with this presentation? A. Hypovolemic hyponatremia. B. Euvolemic hyponatremia. C. Hypervolemic hyponatremia. D. Pseudohyponatremia. Answer: C. Hypervolemic hyponatremia. Rationale: heart failure leads to fluid retention due to decreased cardiac output and RAAS activation. Total body sodium increases, but water retention is greater, causing dilutional hypervolemic hyponatremia with edema and pulmonary congestion. Question 4. A client with severe hyponatremia, sodium 110 milliequivalents per liter, is receiving 3% hypertonic saline. Which finding indicates overly rapid correction? A. Increased urine output. B. Sudden dysarthria and spasticity. C. Blood pressure of 100/60 millimeters mercury. D. Serum sodium rising to 118 milliequivalents per liter in 24 hours. Answer: B. Sudden dysarthria and spasticity. Rationale: overcorrection can cause osmotic demyelination syndrome, central pontine myelinolysis, presenting with neurologic deterioration such as dysarthria, spasticity, and paralysis. Sodium should not increase more than 8 to 12 milliequivalents per liter in 24 hours. Question 5. A marathon runner collapses after drinking excessive water during the race. Serum sodium is 124 milliequivalents per liter. Which mechanism explains this electrolyte imbalance? A. Excessive sodium intake. B. Dilutional effect from free water intake. C. Increased aldosterone secretion. D. Renal failure. Answer: B. Dilutional effect from free water intake. Rationale:
Excessive water intake without electrolyte replacement dilutes serum sodium, leading to exercise-associated hyponatremia. This is dilutional hyponatremia from hypotonic fluid overload. Question 6. A client with thiazide diuretic use presents with weakness and confusion. Labs show sodium 121 milliequivalents per liter and low urine osmolality. Which intervention is most appropriate? A. Continue thiazide therapy. B. Administer desopressin. C. Discontinue thiazide and initiate isotonic saline. D. Restrict sodium intake. Answer. C. Discontinue thiazide and initiate isotonic saline. Rationale. Thiazides promote sodium loss, leading to hypovolemic hyponatremia. Treatment includes stopping the diuretic and restoring volume with isotonic saline to correct sodium safely. Question 7. A client with sodium 126 milliequivalents per liter reports headache and mild nausea, but is alert and oriented. Which treatment is most appropriate initially? A. Rapid bolus of 3% saline. B. Fluid restriction. C. Hemodialysis. D. D5W infusion. Answer. B. Fluid restriction. Rationale. Mild symptomatic hyponatremia without severe neurologic signs is often managed conservatively with fluid restriction, especially in SIADH. Hypertonic saline is reserved for severe symptoms. Question 8. Which assessment finding is most consistent with acute hyponatremia developing within 24 hours? A. Gradual personality changes. B. Bone fractures. C. Seizures and decreased LOC. D. Chronic fatigue. Answer. C. Seizures and decreased LOC. Rationale. Acute hyponatremia causes rapid cerebral edema due to water shifting into brain cells, leading to severe neurologic manifestations including seizures and decreased level of consciousness. Question 9. A client with cirrhosis has sodium 128 milliequivalents per liter and ascites. Which laboratory finding would the nurse expect? A. Low urine sodium. B. High serum osmolality. C. Elevated hematocrit. D. Decreased ADH. Answer. A. Low urine sodium. Rationale. Cirrhosis causes hypervolemic hyponatremia with secondary aldosterone activation, leading to sodium retention but dilution from water excess. Urine sodium is typically low due to RAAS activation. Question 10. Which medication places a client at highest risk for developing SIADH-related hyponatremia? A. Lithium. B. Carbamazepine. C. Furosemide. D. Prednisone. Answer. B. Carbamazepine. Rationale. Carbamazepine enhances ADH effect and can precipitate SIADH, leading to dilutional hyponatremia. Question 11. A 72-year-old client with chronic hyponatremia, Na 124 milliequivalents per liter for 2 weeks, is admitted for confusion. The provider prescribes 3% saline at 100 milliliters per hour. After 6 hours, sodium increases to 132 milliequivalents per liter. What is the nurse's priority action? A. Document improvement and continue infusion. B. Slow or stop the hypertonic saline infusion. C. Administer loop diuretics. D. Encourage oral sodium intake. Answer. B. Slow or stop the hypertonic saline infusion. Rationale. Sodium increased 8 milliequivalents in 6 hours, too rapid for chronic hyponatremia. Overcorrection risks osmotic demyelination syndrome. Correction should not exceed 8 to 12 milliequivalents in 24 hours. Immediate adjustment is required. Question 12. A client with traumatic brain injury develops polyuria, hypotension, and sodium of 158 milliequivalents per liter initially. 2 days later, sodium drops to 121 milliequivalents per liter with low urine output. Which condition explains the sodium drop? A. Diabetes insipidus. B. Cerebral salt wasting. C. Syndrome of inappropriate antidiuretic hormone. D. Acute renal failure. Answer: C. Syndrome of inappropriate antidiuretic hormone. Rationale: TBI can initially cause DI, hypernatremia, from water loss. Later, excess ADH secretion may occur, leading to water retention and dilutional hyponatremia with low urine output, classic SIADH pattern. Question 13. A client with sodium 119 milliequivalents per liter develops tonic-clonic seizures. Which prescription should the nurse anticipate? A. 0.45% normal saline. B. 3% hypertonic saline bolus. C. Lactated Ringer's infusion. D. Oral sodium chloride tablets. Answer: B. 3% hypertonic saline bolus. Rationale: severe symptomatic hyponatremia with seizures requires rapid, controlled correction using hypertonic saline to reduce cerebral edema. Hypotonic solutions would worsen the condition. Question 14. A client with psychogenic polydipsia presents with sodium 123 milliequivalents per liter. Which assessment finding supports this diagnosis over SIADH? A. High urine osmolality. B. Concentrated urine. C. Dilute urine with low specific gravity. D. Elevated urine sodium. Answer: C. Dilute urine with low specific gravity. Rationale: psychogenic polydipsia causes excess water intake leading to dilute urine. In SIADH, urine is inappropriately concentrated due to ADH activity. Question 15. Which client is at greatest risk for developing acute symptomatic hyponatremia? A. 80-year-old with chronic heart failure. B. Post-operative client receiving hypotonic fluids. C. Client with compensated cirrhosis. D. Client on chronic fluid restriction. Answer: B. Post-operative client receiving hypotonic fluids. Rationale: acute hyponatremia commonly occurs in hospitalized post-operative clients receiving hypotonic IV fluids. Rapid decline in sodium increases cerebral edema risk. Question 16. A client with SIADH has sodium 125 milliequivalents per liter. Which lab pattern is expected? A. Low urine osmolality, low urine sodium. B. High urine osmolality, high urine sodium. C. High serum osmolality. D. Elevated hematocrit. Answer: B. High urine osmolality, high urine sodium. Rationale: SIADH causes water retention with inappropriately concentrated urine and increased urinary sodium excretion despite hyponatremia. Question 17. A client with sodium 128 milliequivalents per liter is asymptomatic. Which intervention is most appropriate? A. Administer hypertonic saline. B. Initiate seizure precautions. C. Monitor neurologic status and restrict fluids. D. Begin rapid sodium correction protocol. Answer: C. Monitor neurologic status and restrict fluids. Rationale: Mild asymptomatic hyponatremia is managed conservatively. Aggressive correction is unnecessary and may cause harm.
Question 18. A client with severe burns develops sodium 130 milliequivalents per liter and significant fluid shifts. Which type of hyponatremia is most likely? A. Hypervolemic dilutional. B. Hypovolemic hyponatremia. C. Euvolemic SIADH. D. Pseudohyponatremia. The correct answer is B. Hypovolemic hyponatremia. Rationale. Burns cause massive sodium and fluid loss through damaged skin, leading to true sodium deficit and hypovolemic hyponatremia. Question 19. A client's sodium rises from 118 to 124 milliequivalents per liter in 24 hours during treatment. Which finding suggests safe correction? A. Development of muscle rigidity. B. Improvement in headache. C. New onset dysphagia. D. Spastic quadriparesis. The correct answer is B. Improvement in headache. Rationale. Gradual improvement in neurological symptoms indicates appropriate correction. Neuromuscular rigidity and quadriparesis suggest osmotic demyelination. Question 20. Which client with hyponatremia requires immediate intervention? A. Sodium 131 milliequivalents per liter with mild nausea. B. Sodium 128 milliequivalents per liter with fatigue. C. Sodium 120 milliequivalents per liter with vomiting and confusion. D. Sodium 129 milliequivalents per liter with stable vitals. The correct answer is C. Sodium 120 milliequivalents per liter with vomiting and confusion. Rationale. Severe hyponatremia, less than 125 milliequivalents per liter, with neurological symptoms requires urgent management due to risk of cerebral edema and herniation. Question 21. A 60-year-old client with chronic alcoholism presents with sodium 112 milliequivalents per liter. The provider prescribes cautious correction with 3% saline. Which factor places this client at highest risk for osmotic demyelination syndrome during treatment? A. Age over 60. B. Chronic nature of hyponatremia. C. History of alcohol use disorder. D. Presence of confusion. The correct answer is C. History of alcohol use disorder. Rationale. Alcoholism, malnutrition, liver disease, and chronic hyponatremia significantly increase risk for osmotic demyelination if sodium is corrected too rapidly. These clients require extremely cautious correction. Question 22. A client with sodium 125 milliequivalents per liter has glucose 600 milligrams per deciliter. Which is the most accurate interpretation? A. True severe hyponatremia. B. Pseudohyponatremia due to lab error. C. Hypertonic hyponatremia due to hyperglycemia. D. Hypovolemic hyponatremia. Answer. C. Hypertonic hyponatremia due to hyperglycemia. Rationale. Severe hyperglycemia causes water to shift from intracellular to extracellular space, diluting sodium. This is translocational, hypertonic hyponatremia, not true sodium loss. Question 23. A client with Addison's disease presents with sodium 122 milliequivalents per liter, potassium 5.8 milliequivalents per liter, and hypotension. Which mechanism explains the hyponatremia? A. Excess ADH secretion only. B. Aldosterone deficiency causing sodium loss. C. Renal water retention from SIADH. D. Excess cortisol production. Answer. B. Aldosterone deficiency causing sodium loss. Rationale. Addison's disease causes mineralocorticoid deficiency, leading to sodium wasting and potassium retention. This produces hypovolemic hyponatremia with hyperkalemia and hypotension. Question 24. A client with sodium 118 milliequivalents per liter is lethargic. The nurse prepares to administer 100 milliliters of 3% saline over 10 minutes. What is the primary goal of this intervention? A. Normalize sodium immediately. B. Raise sodium by 1 to 2 milliequivalents rapidly to reduce cerebral edema. C. Correct sodium to 135 milliequivalents per liter. D. Replace total body sodium deficit. Answer. B. Raise sodium by 1 to 2 milliequivalents rapidly to reduce cerebral edema. Rationale. In severe symptomatic hyponatremia, small boluses of hypertonic saline are used to slightly increase sodium quickly to reduce brain swelling, not to fully normalize sodium immediately. Question 25. Which client requires fluid restriction as first-line therapy? A. Hypovolemic hyponatremia from vomiting. B. SIADH with sodium 124 milliequivalents per liter. C. Burn client with fluid losses. D. Adrenal insufficiency. Answer. B. SIADH with sodium 124 milliequivalents per liter. Rationale. SIADH is dilutional hyponatremia due to excess ADH. Fluid restriction is the cornerstone of treatment. Question 26. A client receiving oxytocin infusion during labor develops confusion and sodium 121 milliequivalents per liter. What is the underlying mechanism? A. Increased aldosterone. B. ADH-like effect causing water retention. C. Sodium loss through kidneys. D. Hyperglycemia. Answer. B. ADH-like effect causing water retention. Rationale. Oxytocin has ADH-like properties, leading to water retention and dilutional hyponatremia if excessive fluids are administered.
Question 27. A client with sodium 129 milliequivalents per liter has serum osmolality 290 milliosmoles per kilogram. Which condition is most likely? A. True hypotonic hyponatremia. B. Pseudohyponatremia from hyperlipidemia. C. SIADH. D. Cerebral salt wasting. Answer. B. Pseudohyponatremia from hyperlipidemia. Rationale. Normal serum osmolality with low sodium suggests pseudohyponatremia, often due to high lipids or proteins interfering with lab measurement. Question 28. A client with sodium 117 milliequivalents per liter develops bradycardia and irregular respirations. What complication is occurring? A. Osmotic demyelination. B. Increased intracranial pressure from cerebral edema. C. Hyperkalemia. D. Metabolic alkalosis. Answer. B. Increased intracranial pressure from cerebral edema. Rationale. Severe acute hyponatremia causes water to enter brain cells, leading to cerebral edema and signs of increased intracranial pressure. Question 29. Which medication would most likely worsen hyponatremia in a client with SIADH? A. Tolvaptan. B. Normal saline. C. Desmopressin. D. Fluid restriction. Answer. C. Desmopressin. Rationale. Desmopressin is a synthetic ADH analog and would worsen water retention in SIADH, further diluting sodium. Question 30. A client treated for chronic hyponatremia suddenly develops difficulty speaking and swallowing 3 days after correction. Which condition is suspected? A. Cerebral edema. B. Stroke. C. Osmotic demyelination syndrome. D. Hypoglycemia. Answer. C. Osmotic demyelination syndrome. Rationale. Delayed neurologic deterioration after rapid sodium correction is classic for osmotic demyelination syndrome, particularly in chronic hyponatremia cases. Question 31. A client with chronic SIADH, sodium 122 milliequivalents per liter, is started on tolvaptan. 12 hours later, urine output significantly increases and sodium rises to 130 milliequivalents per liter. What is the nurse's priority concern? A. Development of hypernatremia. B. Risk of osmotic demyelination from rapid correction. C. Fluid volume deficit. D. Renal failure. Answer. B. Risk of osmotic demyelination from rapid correction. Rationale. Tolvaptan blocks ADH, causing rapid free water excretion. A sodium increase of 8 milliequivalents per liter within 12 hours may exceed safe correction limits, especially in chronic hyponatremia, increasing risk for osmotic demyelination syndrome. Question 32. A trauma client develops hyponatremia with low serum osmolality, high urine sodium, hypotension, and high urine output. Which diagnosis is most likely? A. SIADH. B. Cerebral salt wasting. C. Psychogenic polydipsia. D. Hypervolemic hyponatremia. Answer. B. Cerebral salt wasting. Rationale. Cerebral salt wasting presents with hyponatremia, hypovolemia, high urine sodium, and high urine output. Unlike SIADH, clients are volume depleted and hypotensive. Question 33. A client with sodium 115 milliequivalents per liter is intubated for airway protection. Which additional order should the nurse question? A. Seizure precautions. B. Hypertonic saline infusion. C. Hypotonic maintenance IV fluids. D. Frequent sodium monitoring. Answer. C. Hypotonic maintenance IV fluids. Rationale. Hypotonic fluids would worsen dilutional hyponatremia. In severe cases, isotonic or hypertonic solutions are indicated depending on symptoms. Question 34. A client with congestive heart failure has sodium 127 milliequivalents per liter and worsening edema. Which treatment is most appropriate? A. Large volume isotonic saline. B. Fluid restriction and loop diuretics. C. Hypertonic saline bolus. D. Increase oral water intake. Answer. B. Fluid restriction and loop diuretics. Rationale. Hypervolemic hyponatremia from heart failure requires reducing excess fluid. Loop diuretics remove water and sodium, and fluid restriction prevents further dilution.
Question 35. A client with acute hyponatremia develops sudden vomiting, headache, and bradycardia. Which pathophysiologic process is occurring? A. Renal sodium wasting. B. Increased intracranial pressure. C. Metabolic alkalosis. D. Osmotic demyelination. Answer: B. Increased intracranial pressure. Rationale: acute hyponatremia leads to rapid cerebral edema due to osmotic shifts into brain cells, causing signs of increased intracranial pressure such as vomiting and bradycardia. Question 36. A client with sodium 124 milliequivalents per liter and cirrhosis has low serum osmolality and low urine sodium. Which mechanism explains this finding? A. Aldosterone suppression. B. RAAS activation causing sodium retention. C. Excess cortisol. D. Water intoxication. Answer: B. RAAS activation causing sodium retention. Rationale: cirrhosis leads to decreased effective circulating volume, activating RAAS. Kidneys retain sodium, low urine sodium, but water retention exceeds sodium retention, producing dilutional hyponatremia. Question 37. A client with hyponatremia is receiving hypertonic saline. Sodium increases from 118 milliequivalents per liter to 126 milliequivalents per liter over 24 hours. Which nursing action is most appropriate? A. Continue current correction rate. B. Increase infusion rate. C. Stop monitoring sodium. D. Administer desmopressin immediately. Answer: A. Continue current correction rate. Rationale: an 8 milliequivalent increase in 24 hours is within safe correction limits for chronic hyponatremia. Continued close monitoring is appropriate. Question 38. A client presents with sodium 130 milliequivalents per liter and serum osmolality 310 milliosmoles per kilogram. Which condition is most likely responsible? A. SIADH. B. Hypovolemic hyponatremia. C. Hypertonic hyponatremia from mannitol. D. Psychogenic polydipsia. Answer: C. Hypertonic hyponatremia from mannitol. Rationale: elevated serum osmolality with low sodium indicates translocational or hypertonic hyponatremia, often caused by hyperglycemia or osmotic agents like mannitol. Question 39. Which client is at highest risk for developing acute cerebral edema from hyponatremia? A. Elderly client with chronic sodium 128 milliequivalents per liter. B. Young female after excessive water intake in short time. C. Client with chronic liver disease. D. Client with nephrotic syndrome. Answer: B. Young female after excessive water intake in short time. Rationale: acute hyponatremia developing rapidly, especially in young individuals, does not allow brain adaptation, leading to higher risk of cerebral edema. Question 40. A client with sodium 121 milliequivalents per liter has stable vitals but worsening confusion. Which is the nurse's priority? A. Encourage oral sodium intake. B. Place client in Trendelenburg position. C. Prepare for controlled hypertonic saline administration. D. Increase free water intake. Answer: C. Prepare for controlled hypertonic saline administration. Rationale: severe hyponatremia with neurological symptoms requires cautious hypertonic saline to prevent progression to seizures and herniation. Question 41. A 55-year-old client with chronic hyponatremia, sodium 119 milliequivalents per liter for 3 weeks, receives hypertonic saline. Sodium increases to 128 milliequivalents per liter in 10 hours. Which intervention is most appropriate now? A. Continue hypertonic saline. B. Administer desmopressin and free water. C. Increase infusion rate. D. Initiate dialysis.
Answer: B. Administer desmopressin and free water. Rationale: a 9 milliequivalents per liter increase in 10 hours exceeds safe correction for chronic hyponatremia. Desmopressin may be given to slow correction and prevent osmotic demyelination. Free water may be used to re-lower sodium if necessary. Question 42. A client with severe vomiting presents with sodium 121 milliequivalents per liter, tachycardia, hypotension, and dry mucous membranes. Urine sodium is low. What is the most appropriate initial treatment? A. Fluid restriction. B. Hypertonic saline. C. Isotonic saline infusion. D. Tolvaptan. Answer: C. Isotonic saline infusion. Rationale: this is hypovolemic hyponatremia from sodium and fluid loss. Volume restoration with isotonic saline suppresses ADH and corrects sodium safely. Question 43. A client with lung cancer has sodium 118 milliequivalents per liter, low serum osmolality, and high urine osmolality. Blood pressure is normal. Which finding would further confirm SIADH? A. Peripheral edema. B. Elevated hematocrit. C. Low serum uric acid. D. Hyperkalemia. Answer: C. Low serum uric acid. Rationale: SIADH often presents with low serum uric acid due to increased excretion. Clients are typically euvolemic without edema or hemoconcentration. Question 44. A client with sodium 117 milliequivalents per liter develops sudden generalized seizures. Which action should occur first? A. Draw repeat electrolyte panel. B. Administer benzodiazepine and prepare hypertonic saline. C. Restrict fluids. D. Administer oral sodium tablets. Answer: B. Administer benzodiazepine and prepare hypertonic saline. Rationale: airway and seizure control are immediate priorities. Hypertonic saline is required for severe symptomatic hyponatremia. Question 45. A client with adrenal insufficiency is treated with hydrocortisone and fludrocortisone. Sodium improves from 122 to 135 milliequivalents per liter over several days. Which mechanism explains the improvement? A. Suppression of ADH only. B. Replacement of aldosterone effect restoring sodium retention. C. Increased water intake. D. Renal sodium wasting. Answer: B. Replacement of aldosterone effect restoring sodium retention. Rationale: fludrocortisone replaces mineralocorticoid activity, correcting sodium wasting in adrenal insufficiency and restoring intravascular volume. Question 46. A client with chronic hyponatremia suddenly becomes quadriparetic and unable to speak 72 hours after correction. MRI would most likely reveal damage in which area? A. Cerebellum. B. Occipital cortex. C. Pons. D. Frontal lobe. Answer: C. Pons. Rationale: osmotic demyelination syndrome, central pontine myelinolysis, primarily affects the pons, causing paralysis, dysarthria, and dysphagia after rapid correction. Question 47. A client with sodium 124 milliequivalents per liter has serum osmolality 260 milliosmoles per kilogram and urine osmolality 600 milliosmoles per kilogram. Blood pressure is normal. What is the most appropriate first-line management? A. Isotonic saline bolus. B. Fluid restriction. C. Hypertonic saline infusion. D. Increase oral fluids. Answer: B. Fluid restriction. Rationale: low serum osmolality with inappropriately high urine osmolality and euvolemia indicates SIADH. Fluid restriction is first-line therapy. Question 48. A client treated for diabetic ketoacidosis has sodium 126 milliequivalents per liter and glucose 700 milligrams per deciliter. After glucose correction, sodium increases to 134 milliequivalents per liter without sodium administration. What explains this? A. Laboratory error. B. Renal sodium retention. C. Correction of translocational hyponatremia. D. Excess aldosterone. Answer: C. Correction of translocational hyponatremia. Hyperglycemia causes dilutional hyponatremia by shifting water extracellularly. As glucose normalizes, water shifts back intracellularly, raising measured sodium. Question 50. Which hospitalized client is at greatest risk for developing acute hospital-acquired hyponatremia? A. Client receiving isotonic saline. B. Post-operative pediatric client receiving hypotonic IV fluids. C. Client on loop diuretics with fluid restriction. D. Client with chronic renal failure. Answer: B. Post-operative pediatric client receiving hypotonic IV fluids. Rationale: children are particularly vulnerable to acute cerebral edema from hypotonic IV fluids due to increased ADH release post-operatively. Question 50. A client with sodium 118 milliequivalents per liter is lethargic but arousable. The nurse must choose between immediate hypertonic saline or awaiting lab confirmation. What is the best action? A. Wait for repeat lab result. B. Begin fluid restriction only. C. Initiate controlled hypertonic saline while monitoring closely. D. Encourage oral electrolyte drinks. Answer: C. Initiate controlled hypertonic saline while monitoring closely. Rationale: severe symptomatic hyponatremia requires urgent treatment to prevent cerebral edema progression. Waiting may result in seizures or herniation.
Congratulations! You've just mastered 50 clinically challenging hyponatremia questions, from hypovolemic to hypervolemic, SIADH, adrenal crises, and even the dreaded osmotic demyelination traps. Remember, always check volume status first. Watch correction rates. Slow and steady saves the ponds. Differentiate acute versus chronic, hypertonic versus hypotonic, and drug-induced causes. Prioritize neurologic symptoms. Seizures and confusion are emergencies. If you want more high-yield NCLEX content like this, hit like, subscribe, and turn on notifications so you never miss a professional-level review. This is MCQs Master 101, simplifying complex NCLEX concepts one question at a time.